Wound Care for the Home Care Patient webinar, presented by the Visiting Nurse Associations of America. Carol Jones, today's presenter, works with the VNAA Care Network in Hospice in Danvers, Massachusetts, and is a certified wound ostomy continence nurse. Today's presentation is based on her poster presentation, which won VNAA's 2016 Innovative Practice Award. I'd now like to turn the presentation over to Carol.
Hi, thank you so much for joining me this afternoon to talk about cost saving for wound care patients in the home care setting. Just to give you a little background on myself, I have worked in home care for 35 years. So for any of you who have also done that, you know that I've experienced all of the changes that have gone along with home care, and I've actually run the WOC program at the VNAA Care for the last 20 years. So as you know, wound care is very challenging and very costly, and it is imperative that we work at having cost savings with our wound care patients. So I hope to show you ways to do this and to accomplish this today. So I want to tell you just before we even start what I'm going to be doing in this program so you know where we're headed and know what we're going to be doing. I'm going to talk about a holistic approach to wound care, how to choose wound care products, the products themselves that you should have on your formulary, how to develop a formulary that is cost effective, and then we're going to talk specifically about my poster, how I came to do it, and about the product that I used. Next slide, please. So here's today's objectives. Describe 3 factors directly affecting wound healing. Identify 2 principles for choosing a topical dressing. And discuss 2 reasons for lack of patient participation in their own wound care. Next slide, please. Okay, we're going to talk about the principles of wound care. Next slide. So you may be thinking that we're going to talk about products, but you know what? We're not going to talk about products for a long time, because the last thing you look at when you're talking about wound care is what are you going to put on that wound. Because I can put any number of dressings on a wound, and if all the other things are in place for wound healing, that wound will heal. Next slide, please. So let's look at factors influencing wound healing. We're going to spend a little bit of time on this page. You may want to take notes, because this is the gut about wound care. This is what is really important when we're looking at wound care. So in home care, we know we always need to say, well, what is the etiology of the wound? That is not as easy as people think it is. Sometimes it's actually very difficult when you're answering those OASIS questions. What kind of wound is this? Is this a vascular wound such that it's arterial? And if it is, do they need a vascular assessment? You don't want to wait while you're trying to heal these wounds to figure out 3 months later, oh, maybe we better get a vascular assessment. You need to be looking at the blood flow to those legs. Anytime you've got wounds on a leg or a foot, do they have blood flow? Because if they don't, immediately you want to be seeking a vascular consult. Is it a diabetic wound? A diabetic wound for OASIS purposes is going to be most often on the toes or the plantar of the foot on a diabetic patient. For diabetic patients, we need to be looking at their glucose control. If their blood sugars are not in control, they are not going to be healing. Thankfully, OASIS makes us do diabetic foot teaching within our episodes. That's a great thing so that we can be helping our diabetic patients out. Diabetics need to have glucose control, and they need to be offloaded. Is it a pressure wound? So pressure wounds are going to be over bony prominences. If the wound is clean, which means you have removed the necrotic tissue, and we'll be talking a little bit more about this, pressure wounds will heal if there's not infection, if you feed them, and if you offload them. You need to know, what do people qualify for in terms of offloading equipment? Do they need a mattress? Do they need a seat cushion? Based on your Braden scale, you should be putting these interventions in place, not waiting for wounds, but putting those interventions in place immediately. Venous stasis wounds. Are they using compression? If your venous stasis patients who only have venous insufficiency and do not have a combination of arterial disease are not using compression or refusing to use compression, they will not heal. You will have them forever. So we really need to be dealing with individual patients and their needs. What kind of compression will they wear? What kind of compression can they get on easily? What kind of compression can we put them in for discharge so that we don't have them back in 3 weeks? These are the things that we need to be dealing with in order to decrease the frequency of our visits and the cost of wound care. Skin tear, trauma wounds, and other wounds, those weird wounds. And there's so many weird wounds out there, and what I can say to you is if a wound isn't making sense, you need to get that patient to a place where someone can look at it in a different way. Do they need to see derm? Do they need to see a wound clinic? Does the wound need a biopsy? When wounds are not making progress, the rule of thumb is absolutely to biopsy a wound within 6 months. I say do it sooner because we do not want to be hanging out doing wound care 2, 3, 4, 5, 6, 7 days a week without making progress. We need to be looking at, are the wounds making progress, and if not, why not, so that we can be moving them forward. You always want to be looking at nutrition with your wounds. All of your nurses should be dealing with nutrition, and or if you have specialists available, dietitians, nutritionists, diabetic nurses, to do nutrition teaching with patients. High protein, high calorie diets. Now I'm going to tell you, we say that patients don't know what protein is. Patients all have differing diets these days and nutrition needs. You know, half of our population is doing gluten-free, the other half is vegan. So we need to be looking at what individual patients will eat, teaching them what protein is, and then teaching them you need to be doing protein 3 meals a day and with snacks, and you need to be doing calories. At 10% weight loss, nutrition, wound healing is going to be impaired. So how many people go in the hospital and come out with a 10% weight loss? So many of them do. This is going to impair your wound healing. So you really need to be looking at nutrition from the get-go, working with that individual patient as to what they will eat, what they can afford to eat, what they can afford to purchase in terms of products for wound healing. You need to be looking holistically at this patient. We're not just looking at a wound. The reason our wounds don't heal is that, for one, our patients have so many comorbidities. So not only do we have maybe a straightforward abdominal incision, but that patient also has lupus, rheumatoid arthritis, scleroderma, severe cardiac disease, where they're not being well perfused. Remember, if you don't have oxygen, you're not going to heal. Or they have any number of the major inflammatory conditions, some of which I just listed, and others being things like ulcerative colitis or Crohn's. All of these diseases are going to interfere with wound healing because they are inflammatory diseases. Wounds have to go through a very short inflammatory process on day 3, but it needs to end within 3 days. You want 3 days of an inflammatory process, but when we have patients who have inflammatory diseases and are on anti-inflammatory medications, these wounds are not going to heal in a timely fashion. That's why we have chronic wounds and we have jobs. We want to be looking at infection. If a wound is not making progress, one of the things we need to be looking at is it infected? Even if it is not grossly infected, showing the erythema and induration, Is there such a high bioburden in that wound that we need to be culturing it or biopsying it to see what bacteria is growing in it? I've done this, over and over, and invariably these patients are infected with MRSA, and once they're treated, they go on to heal. You want to be looking at your wounds. If a wound has necrotic tissue in it, necrotic tissue is dead tissue. It is your slough, your yellow tissue, or your eschar. You do not want to hang around doing wet to dry dressings to try and remove that, because you will still be doing wound care for 6 months. You need to be aggressive about getting that dead tissue out of wounds. If you have the ability to send a patient out to a surgeon to get it debrided, do that. Otherwise, you need to be using products that are going to debride that wound most quickly, and we are going to be talking about products later in the program. Need to be addressing incontinence, because what does incontinence do? It damages skin. Then you add a little shearing, which is related to pressure, or a little pressure, and you have skin damage. We shouldn't just be checking off on OASIS, yes, your patient is incontinent. We need to be dealing with this. We need to be dealing with skin issues related to incontinence. Do they need moisture barriers? Do they need products such as briefs or pads? Are their caregivers able to adequately care for them, to change them at the needed times, to turn them, to give them good care? These are all issues that are going to affect wound healing and thus the costs of wound care. Medications. We need to look at those medications. Our patients are on a lot of medications that interfere with wound healing. We all know, if I asked you, you'd say, oh yeah, prednisone, steroids, and you're correct. But nowadays, if you watch TV for 2 hours, you're going to see advertisements for, 4 or 5 different anti-inflammatory drugs. Remember, I just said wounds have to go through an inflammatory process and then move on. When they are on anti-inflammatory drugs, the wounds do not move on in a timely fashion, and these wounds will take longer to heal. Then there are medications that we know are great. The wounds are infected. Our patients are on antibiotics. Great. They need the antibiotics to take care of the infection, but what else happens? We just talked about patients needing nutrition for wound healing, and now they're feeling vaguely nauseous, sometimes more than vaguely nauseous. They have diarrhea. Their appetite is suppressed. So you can start to see when we talk about these things how complicated wound healing is. And that anybody heals it all is actually, in my mind, really amazing. You need to look at vascular status, and your nurses should be documenting in the records the vascular status. Are the feet warm? Can they feel the pulses? They need to be documenting whether they can feel the pulses. If you have staff who have Dopplers, they may want to be doing ABIs prior to putting compression on patients. If people do not have blood flow, they are not going to heal. And this is a group that has to go out to see vascular surgeons, or we need to be changing the goal to maybe not be healing. If the vascular wound is venous related, they need to be using compression or they will not heal, and we will have them forever. And you need to be talking about your patients who are non-adherent to that. Bring that to the table. Find out why they're non-adherent and see if there's not another way to come about helping with compression that they actually will comply with. We all know that smoking interferes with wound healing, decreasing oxygenation, and bringing all of those wound healing products to the patient. We do as much as we can do to decrease smoking, even if they can decrease some. I've never smoked, but I was outside of a gas station yesterday and I saw cigarettes advertised for, I think it was $9.80 a pack. If that's correct, I don't know how anybody is smoking. But we all know it's an addiction and one that's hard to get rid of. Obesity. I'm sure that you are seeing in your population, just like I am, more wounds related to obesity, especially in that C-section population. because fat does not heal. Fat does not have a good blood flow, and it does not heal. So we may not be immediately able to affect that, but when we have those wounds, we know why they're going to take a long time to heal and why we may be needing to find ways to help our patients participate in their wound care and decrease our visits because we can't be doing it all for them. Next slide, please. So before we go on to talk exactly about how what we're gonna consider in choosing wound dressings, I just briefly wanted to give you one slide on wound cleansers because they're so important. It's so important that we're not using cytotoxic products to clean our wounds. We should be using saline or wound cleaners if you want to be providing those for your patients. Showers are great. If most of my physicians will agree to patients getting in the showers for cleaning their wounds. We should not be using products such as betadine and hydrogen peroxide anymore in our practices. These are not best practice. Products such as sodium hypochlorite, which is Dakins, or acetic acid should only be used briefly. And by briefly, I mean 1 to 2 weeks to decrease known bacteria. They work. They're great. They will kill bacteria. They also kill healthy cells. So those should be used short-term, 1 to 2 weeks, for cleaning up bacteria in wounds. All right, next slide, please. So let's look at the general principles of choosing a wound dressing. And I know when we get to wound products, guys, I talk in terms of categories of products. I generally don't talk about specifics. I can talk about specifics if you have a question about specific products. But we're going to talk about principles first of how do you choose a product. You need to fill dead space. That means if you have tunnels, undermining, or deep wounds, you need to be filling them with something, not just putting something on top of them. We need to be doing moist wound healing. Moist wound healing has been best practice, standard of care now for probably at least 30 years. In the end, in your bibliography, I actually cite an article, which is actually an old article now by Lisa Ovington, Hanging Wet to Dry, Out to Dry. If you need an article that looks at the wet to dry issue, it's a great article. You can hand it out to physicians, to your staff, on why we don't do wet to dry. Wet to dry means you're putting something in wet, you're pulling it out dry. It's painful. There are better ways to debride. There are better ways to do moist wound healing. And actually they have found that bacteria can get through gauze much more easily than advanced wound care products. Those are some of the reasons why we don't do wet to dry. We need to be healing our wounds in a moist environment, but we need to be choosing dressings that allow the wound to be moist but not drowning in moisture. So we'll talk about that a little bit more. We need to be getting rid of our necrotic tissue. I already talked about that. Sending patients out to surgeons. Do not wait. If you've got eschar that's loose and brown and stringy yellow underneath it, get them out to somebody that will debride them. That's going to be your fastest way of debriding that wound so that you can move it onwards. You are not going to move it onwards by doing wet to dry or even things like Santal on those wounds if they are full of necrotic tissue. You need to identify and eliminate infection. Teach your staff the proper ways of doing cultures. I just taught orientation yesterday, and I said to the orientation group, tell me, do you clean the wound before you culture it or not? And half of them said not. It's not the correct answer. So I presume people know these things, but they don't. So you need to be teaching your staff how to do those things. You want to absorb excess exudate, but not dry out the wound. So there's this fine balance in wound care of having the wound moist, but not too moist. And that's how one of the ways you're going to determine the frequency of wound care. That you want the wound to be moist enough so that new cells can be moving across that scaffolding, but not so moist that it's drowning. provide thermal insulation, which many of our dressings do, protect the healing wound, and protect the peri-wound skin. You want dressings that are going to protect the skin around the wound as well, or you need to be using a protectant around that wound so that the skin is not breaking down around your wound. All right, next slide, please. So how do we choose wound dressings? Scratching their head, lots to consider. Let's go to the next slide. Is the wound wet or dry? If the wound is dry, we need to add moisture. And we're not talking about wet to dry, we're talking about products that add moisture. If the wound is very wet, we're going to use products that absorb lots of drainage and or do it more frequently. What type of tissue is in that wound bed? If it's beautiful, pink, healthy granulation, you only need to be growing new tissue. If it's necrotic tissue, especially if you've already had it debrided and there's still necrotic tissue, we want to be using products that continue to get rid of necrotic tissue. We have products specific for that. We already talked about looking at infection, wounds that require debridement, pain management. We need to be looking at products that decrease the pain with wound care. That has been one of the things that CMS has been requiring from us, is to look at pain management with our patients. How often in a record do you see that the only time the patient has pain is with wound care? A lot of these products that we use will help decrease pain, especially the product that I did my poster on, Polymem. When we talk about that later, we'll talk about its use in decreasing pain with wound care. But many of the products will help decrease pain over products like wet to dry or things that you're pulling out of wounds. I've had people so anxious needing to take Xanax and Ativan before wound care because of the fear of the pain. You need to know the location of your pain, your wound, because that's going to also influence the type of dressing and possibly the frequency, and or whether the patient can participate in the wound care or you need a caregiver. And leading into that, is the patient or caregiver capable of learning wound care? Now let's just spend a minute on this one, because this is a big one in home care. And I am going to tell you, patients are much more capable than they let on, many of them. They also have people coming in and out of their houses. So here's a little example. I went to see a patient that I was told there was absolutely nobody who could do the wound care. The patient lived alone in elderly housing. I walked in to see her, and there was a table full of people eating donuts. I wanted one of the donuts. But I said to them, how often do you do this? We do this every morning. They come over for donuts and they leave. I said, who would be willing to help me with the wound care? And a couple of them raised their hands. People are coming in and out of these houses that can help people with wound care. Do I know that there are absolutely people who have no one? Of course I know that. Remember, I've done home care for 35 years. But many people do have people coming even if they're only coming on the weekends, or their family members are bringing their groceries in twice a week. Right there, we're not going to be doing daily because we've got somebody who can participate intermittently. Patients, especially when we go to talk about my poster, and this is the reason I did my poster, is I was looking for a product that would make it easy for patients to do their own wound care. We need to make it easy. We need to make it so they can do it. And then when we are teaching patients or family members to do wound care, I always say to them, we're not leaving you. We're not trying to get out of here. Our job is to be the skilled assessors and teachers. If you see this wound on a day we're not here and you think it's deteriorating, you call us and we'll come out sooner and take a look at this wound. You have access to us. We can make a phone call to see how you're doing. But this is a great way to decrease visits for wound cares and yet support the patient and the family. We want to be looking at how frequently dressings need to be changed. I am going to tell you there are hardly any wounds that need daily. The only wounds that I would see that need a daily visit are wounds that are so sick and fragile that they may need a skilled assessment daily for a very short period of time, or there is so much exudate in that wound that I cannot get it down to less than daily until possibly I can get something like a VAC on it, or I can teach a family member to do that. Those are the only wounds that I see needing to be done daily. The other thing is you want to check to see if dressings are compatible with other dressings. I see a lot of products being mixed. Sometimes that's fine. But if you don't know if products can be mixed, you need to be asking the company that gave you the product or made the product. Santal actually has a list, I think it's on their website, of compatible products with Santal. I would have told you not to use Santal with anything other than a cover dressing and gauze, which is how they say it should be used. But it actually is compatible with several different types of dressings, and they do have that on their website so that you can know what it is compatible with. You need to be following best practice standards. You need to know those best practice standards because that is what you are going to be held to. Wet to dry is not best practice. Wet to dry is not moist wound healing. On OASIS, you are asked, with your pressure wounds, are you using moist wound healing? You do not want to be saying no. If you want improved scores, you want to be saying yes. And then you want to look at what is the goal of this wound. I would say, you know, hopefully for 80 to 90% of our wounds, the goal will be healing. Occasionally you're going to have wounds where the goal is not healing. And it will not heal. It may be a cancer wound. It may be a vascular wound that's already been revascularized, can't be done again. So then the goals change to teaching someone and providing wound care that keeps that wound uninfected and it provides comfort for that patient. Okay, next slide, please. Okay, always seek knowledge. You need to know. Next slide, please. So we're going to talk, and I'm going to do this briefly, but you will have this in your reference material. I don't want to spend, we've got another 32 minutes together. I don't want to spend all of our time talking about all these different products. Some of you probably are already very familiar with them. But I wanted to show you the basic products that you should be having and using with your population in the home care setting. These are all products that CMS would say, or Medicare would say, that you have to provide for your patients. But I just wanted to show you how you can use these products to decrease the frequency of wound care in your home care population. So the first one I've used, and I've given you pictures here because, you know, I found a couple pictures. There are 30 of these on the market. So you need, and we're going to talk about how to do a formulary too. So a hydrogel is indicated for partial or full thickness wounds. It is a water or glycerin-based gel. It is very smooth and silky. It really adds some nice moisture to that wound. So for that wound where they're doing wet to dry and it's coming out dry, it's killing the patient, or you go out and assess that patient, there's barely any drainage and you need a little more moisture so that wound is going to close, this is a great product. This only needs to be done every 2 to 3 days. It is usually used as a, we'll need a secondary dressing over top, so whether it's a wrap or ABD or cover dressing. But every 2 to 3 days, most hydrogels can be done. Next slide, please. Hydrocolloids have been around. I remember my first in-service on hydrocolloids was 35 years ago. That's how long they've been around. It's occlusive or semi-occlusive. The one name that everybody knows is Duoderm, but once again, there are a million of these on the market now. And they provide limited to moderate absorption and insulate the wound, moist wound healing. They protect it from bacteria. And these are generally used for stage 2 or shallow stage 3 wounds. They will do some debridement in a shallow stage 3 wound that has a little bit of slough, and they are generally changed every 2 to 4 or 5 days. Next slide, please. Alginates. Alginates are made from seaweed, so you have to remember when you take it off, it may be a little smelly and it may be a little green, but they absorb up to 150 times their weight. So you want to be using alginates in wounds that have a lot of moisture in order to decrease the frequency of your wound care. You're going to leave that wound bed nice, moist, and it's just going to granulate and fill in. These wounds are going to heal faster when they're clean if you just leave them alone. Once again, these can be done every 2 to 5 days. They come in 2x2s. They come in 4x4s. They come in ropes, and there are lots of companies that make them. Next slide, please. So as opposed to alginates, people sometimes put these two products in the same category. Hydrofibers, the one that you know is Aquacel. There are other companies making these now, which is interesting. This is not an alginate. It is a hydrofiber. It absorbs a moderate to large amount of exudate. It turns into a beautiful gel, providing moist wound healing, can be changed every 2 to 7 days. This is a great product for putting down those little narrow tunnels that they come home all the time. Little tiny narrow abdominal wounds, pack daily or BID with iodoform or with new gauze. Use this. Comes in a 1/4 inch ribbon. There are others on the market, so you don't have to just use this one. And as there more and more come on the market, hopefully it will become more cost-effective as well, because this is a rather expensive product. But if you only have to change it twice a week, it decreases the cost of nursing by only doing it twice a week. And you're going to be teaching that family member anyway, so you go out once a week. Next slide, please. Antimicrobial dressings. There are so many of them on the market now. And first I want to say we don't always need to be using antimicrobial dressings. I think, sometimes we think if we do that, the wounds won't get infected. Actually, with silver dressings, they have shown that long-term use of silver may interfere with wound healing. So you need to pick appropriate for the wound. That's the theme here. Individual patient, what's best for that patient. So we all know that there are lots of different antimicrobial products. People know about medical grade honey. There are several on the market. You see one of them down there at the bottom. Medicare, Medicaid are not paying for these. I do have a few patients who end up with it. The wound clinic gives it to them, or the patients choose to purchase it, or private insurance might choose to purchase it. But because it's not being paid for under Medicare, Medicaid, it is difficult to get. There are many gauzes out on the market, or at least several now, that are antimicrobial. They contain polyhexamethylene, PHMB. This is another way to decrease those tiny, narrow tunnel wounds. You can put this antimicrobial gauze down in that tunnel. It can be done every 2 to 3 days instead of your new gauze every day. Sometimes you can change the outer dressing if you have to. But I'm showing you there are all kinds of products here. You do not need to be doing daily wound care. Cadaxim or iodine is a non-cytotoxic iodine product that is a great product, decreases bacteria, but once again, reimbursement is very difficult. Sometimes patients can get it with a script, sometimes they can't. It's been on the market for a long time, but difficult to get. Silver dressings are easy to get. Gels, foams, alginates, every category of product comes in silver. They can generally be left on the wound 2 to 4 or 5 days. You've got, your alginates that will absorb a lot, your gels that will add moisture. Once again, I just say these are more expensive than other products. So decide, do you really need this? Is the wound infected? Is the wound at high risk for infection, such maybe a diabetic wound? They may be the ones that you want to be using antimicrobial dressings on. And then the last one I have there is the methylene blue and Jensen violet. The Ferra blue is the one that I know of. There may be others. Inhibit growth of microorganisms, and that is changed when the blue color changes to white. So I can't give you a specific time period, but most of my patients are leaving that on for 2 to 3 to 4 days. Okay, next slide, please. Transparent films, you are all well aware of these. An occlusive dressing supports autolytic debridement, once again, so if you have a wound that has a little bit of slough, not thick, not 3 inches deep slough, but a little bit, this is a good product for debriding, autolytic debriding. It heals it in a moist wound environment. They can be changed every 2 to 5 days. Some people use these on skin tears. I would probably choose something else, but it's not necessarily something you couldn't use on skin tears. Next slide, please. Debriding agents, we talked about needing to debride wounds. The best thing is to get those wounds out to surgeons and get the dead tissue cut out. But if you have a little bit of slough or eschar that is unable to be surgically debrided, here's 2 products that are great. Santal needs to go on. You need to hear this because this is how this product goes on. Nickel thick with a moist saline dressing over it, generally done daily. The same with Mesalt. Mesalt is a 15% salty gauze. It debrides moist slough, not dry slough, but moist slough really, really nicely. In almost any wound, you need to be finding patients to do these dressings and or caregivers, because these are products that are generally done. I have sometimes seen people do them less than daily. There is a poster that I looked at using Santal with a polymem foam, which is what my poster's on. We're going to look at in a minute, which then you would not have to do daily. There are people who mix the 2 together. I've got a wound clinic that mixes the 2 together, and it works quite effectively. Possibly, you know, could be done every other day, but generally when you're trying to debride wounds, the more often you do it, the more effective it's going to be done. Next slide, please. Foam dressings, you all know about foam dressings. They wick up a lot of fluid, and these can be left in place 2 to 5 days. Next slide, please. Silicone dressings, lots of silicone dressings out there on the market. It has a soft layer of silicone. Instead of, some of our foams used to have, and they still do have, like an adaptic type, that oil immersion dressing on the back. Now our foams have this silicone non-stick. It allows for easy removal, not causing trauma to the wound or surrounding tissue, can be used on fragile skin. It's got moderate to medium ability to absorb exudate, and can be left in place for several days. All right, next slide, please. And collagen, I wanted to put collagen in because collagen is a great wound product. There are many out there on the market now. Some of our patients are deficient in collagen production, particularly diabetics. These products are expensive. So these are not probably going to be your go-to product for a young, healthy person. But for people who have difficult to heal wounds, these may be choices that you want to make once the wound is clean. You don't want to be putting this on a wound that's 100% slough or eschar. You're going to waste your money. You want to get those wounds clean, and then you start using some of these advanced wound care products. But collagen will, I had a patient that we were doing actually for a couple months, 2 or 3 times a week, wasn't making progress. I think we were using a silver alginate, switched him over to one of these products, and in 6 weeks the patient's healed by adding the collagen to that wound. Next slide, please. So the next few slides, we're going to talk specifically about the polymeric membrane dressing. This is the product that I used in my poster in order to promote patient participation in wound care. And so I wanted to spend a little extra time. This product is actually in its own category, although I think it is reimbursed under the foam category. Next slide, please. here are all of the types of wounds that you can use this product on. So I'm not going to read this to you. You have this as a resource. Basically, if you look at this, what this says is you can use this on almost any wound except a 3rd or 4th degree burn. And I do use my wounds, almost all types of wounds, and I've used this on. Next slide, please. So why is Polymem special? It has a moisture-loving matrix. It helps improve healing by focusing inflammation response and increasing perfusion of the wounded area. It has a continuous wound bed cleanser. It cleans the wound, or the wound can be debrided, and then it does clean. It provides or promotes additional cleaning if the wound is soiled or infection is present. This is one of the reasons I use this particular dressing a lot in my practice. This product has a surfactant wound cleaner in it, so my patients do actually not have to be cleaning their wounds. They can take the old dressing off and put the new dressing on. Now, if they want to take the old dressing off and get in the shower and clean it, that's fine. They can do that, but they don't have to do it. It encourages autolytic debridement. And I can tell you it's a foam with this cleaner in, and I do use it on wounds that have some necrotic tissue. Once again, not 3 inches of necrotic tissue, but if I've got a wound with some pink and scattered slough, I will use this product. It will debride the wounds. It reduces the odor, hypergranulation. It wicks up to 10 times its weight, so it absorbs a moderate to large amount of drainage from wounds. It maintains ideal moisture vapor transfer, acts as a barrier to bacteria. And okay, we can go to the next slide. So you can see all of the properties that this dressing has. How do you know when to change it? Honestly, I keep this wound dressing on. I usually change it 2 to 3 times a week. The company says it should be changed at least every 7 days, and when the wound dressing itself is 75% saturated is when you know how to change it. Next slide, please. The other thing with this is, remember, we're always looking at pain and wound care, and it reduces the spread of inflammation. It doesn't interfere with the primary inflammatory response required for healing, decreases pain and anxiety, and minimizes adherence to the wound bed. So there's reduced pain and anxiety with the wound dressings. These are all so important. Next slide, please. So we have talked about how do you decide what dressings to use, how to choose a dressing based on the type of wound, the frequency of wound care, the individual patient's needs, and we have looked at many of the products on the market. I want to spend the next maybe 5 minutes, because this is so important to a cost-effective home care, wound care program, looking at how do you do a formulary. So you need to take the above products, but you don't need to necessarily choose the name everybody knows. We all know those names out there that everybody knows. When I teach orientation and staff have come from other places, they'll say, well, don't you have this name and this name? And I go, nope, we don't. But we have like dressings. You need to have your WOC nurse or your wound care nurses trial similar products to see which ones work best and which ones you like most. You need to set the limit on how many the patient can get in a month without the manager's approval. Medicare tells us how many dressings patients are allowed per month. They also tell us what dressings we have to provide to patients. But you don't have to put that number on your initial formulary. For example, Medicare may say somebody can get 15 foams in a month. But you know this wound is 1 inch. You're going to order a 4x4 foam. You're going to cut it in 4 pieces. You're going to change it twice a week. That one piece of foam should last for 2 weeks. So put down on your formulary that they could get 6 or 8 pieces without having a manager have to approve more. That way, your staff are not going to say, and I have staff who do this, they call our provider and say, give me the most I'm allowed. And then I go in that house, and there's a box of unused product that cost us $150, and I am not a happy camper. So you to look at, well, what's a reasonable amount that a patient might need over a month's period, and make that the number that you'd get on our formulary, knowing that you might have to provide more to some patients, but then it limits the staff's access to the numbers they can get and the types of dressings they can get, thereby saving you money. Then you need to work with your vendors for best pricing on products. Look at prices that maybe they get best pricing on. Ask them for, 2, 3, 4, 5 products within a category. Trial them. See which ones you're happy with. Which ones provide well enough that you may be willing to use that product in place of, possibly another product that would cost you more money. You also want to choose products that are going to help your patients to be independent in their wound care, therefore decreasing your skilled nursing visits and saving time during the visit. Make it easy. Your financial savings will only be as good as your formulary. Next slide, please. So, as I already said, CMS, Medicare tells us what we have to provide to patients. That's a given in terms of the types of products, but you get to choose which products in those categories. Your nurses need to be kept abreast of new products out there. If you've got wound nurses, WOCN nurses, they need to be going to conferences. You need to be bringing vendors in. You need to be asking Byram, what do they have that you, I'm sorry, not Byram, Byram's the company I use, whatever vendor you use, what products can they provide you with within that category that you can trial, see what you like, and see what kind of pricing you can get on them. At the end of the day, you may want to have any products that your staff have ordered that are not on your formulary or are in high numbers that you've set that number, go to a manager or an approving person in your office. You're in charge of this formulary. You get to say, we want, with your staff, you cannot get this product. So it's a new staff member, they only know this name, they forget, oh, you've got this, they order it, it gets through. Somehow, that call needs to come to you or someone designated in your office who will either say, you know what, we will do that, or we need to look into this further and see why the staff member is asking for this number of products. Maybe there's a reason, and maybe there's not. Maybe there's a substitute. For your Medicare patients, I would suggest that you only let them order a 2 to 3 week period of specialty products, because if the product's not working, you're going to be trying something else. If they're going to a wound clinic, they're going to be switching the products up in a week or two. You don't want to be wasting your money on products you can't use. You can't take those products out of the patient's house as much as some of us may want to. We can't do that, and we don't want to see products sitting in patients' houses unused, wasting our Medicare dollars. Next slide, please. So the last part of our presentation, in the last, let's say, hopefully 5-6 minutes, and then we have a few minutes for questions if you have them, is just to look at my poster. Use of bordered polymeric membrane dressing to promote patient participation in their own wound care in the home care setting. Actually, the Ferris company approached me about doing a poster for them. They had some suggestions, and I said to them, this is what I want to do. I've been in home care forever. This is a product that I use to promote patient independence in wound care and decrease the frequency of my visits. Next slide, please. So we did a case study. This is all we included in our case study, but I used this product with literally many patients. Patients who would have found it difficult to do their own wound care, and you guys know the reasons why they find it difficult. The elderly, sometimes multiple steps is too much, tearing tape, you know, cleaning the wound, then putting something on it, then trying to wrap it or trying to get tape on it. Sometimes it's overwhelming, it's challenging, you know, particularly on leg wounds. They might be able to put something on it, but they can't wrap it. So in order to encourage patient independence or participation in wound care, you need to make it very easy. You teach them when to call the VNA, assure them you're not leaving, you're there. If there's a change in the wound, you'll send a nurse out, you'll talk with them over the phone, and you use a product like this polymembrane dressing that I used in this poster. Next slide, please. So here's the dressing change steps. Actually, I'm not going to read this to you. It's because it's just so easy. It's almost like a Band-Aid. You take the backing off, you put the new one on, you take the old dressing off, take the backing off the new one, you place it down, put your hand over it for 1 to 2 minutes, and leave it on for 2 to 4 days. Next slide, please. So here are some patients that I used it on, and you can see how easy this is. This was a chest cancer wound that had been removed. It's like applying a big Band-Aid, but it's got the benefit of this surfactant cleaner in, promoting pain management, absorbing drainage, decreasing inflammation. So he puts that on, he tears off the outer edge, he leaves that on for days, and then he can change it. I come back at the frequency that I think this wound needs to have a skilled nursing assessment. Next slide, please. Here the dressing is in place on his chest. Next slide, please. This is actually a C-section wound that this young woman was able to do independently in between our visits. This was really important because, and this is our population. This young woman not only had a baby, she had a lot of other issues going on. Mental health issues, family issues, all kinds of things. She could have been somebody who we ended up being in there every day or every other day, and I said, here's a really easy dressing. It's got this bordered tape on it. It's going to clean the wound. All you have to do is take the old one off, put the new one on. She was able to do that independently, and it was great. Next slide, please. This is a patient, actually, you can see these old hands. She's in her late 80s. A little bit of necrotic tissue in that wound, which the polymem did clean up. I think we used maybe some a light compression over top of this to be grip for the fluid in her legs. This lady, she was not a healthy late 80s. She had 2 different kinds of cancer. She had an ostomy for one of her cancers. She had lots going on, but you can see sitting on her chair, she was able to bend over, put this dressing on, remove it, and change it with us coming at the frequency that we felt she needed a skilled assessment. Next slide, please. So here is the actual poster. You actually have a copy of that was sent to you that you can use as a reference if you like. And then the next slide, please. So I want to thank you for participating, being here with me today. I just want to review kind of where we've gone. It's so important that you're looking at cost-effective wound care by doing a very holistic approach. The first thing is putting all the pieces in place, looking at all their diagnoses, their meds, what kind of wound is this? Then looking at the tissue type and the amount of drainage to choose the wound product that you are going to use, an advanced wound care product that will not need to be done daily, creating a formulary based around those products, setting limits on your formulary as to the type of products, the amount of products that they can get in a period of time. I can tell you if you do that, you are going to have cost savings because we've proved it in my agency. And then lastly, I loved doing this poster. I love doing this, using this product. I actually tell you one story. I had a patient who was in his 90s who had a cancer removed from the top of his head, and it was draining a lot. And his nurse said to me, he can't see it and he can't do it. I went out to see him, and I thought, well, that's ridiculous. Of course he can see it. It's right in front of him. He had macular degeneration. He could not see it. I took my Bordered Polymem. I put it on his head. He happened to be a very pasty white male. I took a black magic marker, which he let me do, of course, after asking, made marks around his head where the dressing would go. And he could see the black on his skin. He was able then to do that dressing independently. We decreased wound care to once a week. And he did the wound daily, then by decreasing to less than daily after the drainage decreased. And that's it for me. And if you have any questions, I'm happy to take them.
Great. Thank you so much, Carol. At this time, we'll move into the question and answer session of today's call. If you have a question, please use the chat feature at the bottom right corner of your screen. And we did have a question come in during the presentation, so I will go back and pull that right now. One of the participants asks, due to the fact that nurses are so used to cleaning wounds, does cleaning with the wound cleanser or saline affect the dressing's effectiveness?
If you're talking about the Polymem, and they say you don't have to clean the wounds. I do have people who want to clean the wounds, and I guess I would actually have to have the Ferris company speak specifically to that, but I do have my patients, if they really want to clean their wounds or get in the shower, use a wound cleaner, and they're able to do that. Remember, one of the reasons I don't have people to do that is because it's an extra step. If they're able to do that, that's fine with me.
Great, thanks so much. If there are any other questions, please feel free to use the chat box located in the GoToMeeting screen. Okay, well, if there are no other questions, I'd like to take this time to thank you all for joining us for today's webinar. I'd also like to thank our presenter, Carol, for sharing her expertise, time, and commitment to making this a successful program. Thank you again for your participation, and I hope you have a wonderful afternoon.